Hello everyone, and welcome to the University of Minnesota Mini Med School, Bone Health Across the Ages. We are excited to have you here today, and we look forward to guiding you through the final topic in our series, Innovations in Geriatric Bone Health and Joint Care. My name is Ann Van Heest. I'm an orthopedic hand surgeon, and I'm the professor and vice chair of education in the Department of Orthopedic Surgery at the University of Minnesota Medical School. Our department consists of nearly 100 faculty members and affiliated physicians and provides orthopedic care through the mHealth Fairview system, Health Partners, TRIA, Gillette, and CentraCare. We are proud of our orthopedic surgery contributions to patient care, physician education, and cutting-edge research. We will begin tonight with a moderated discussion with 3 presentations. These will be followed by a question and answer session. You can submit your questions to our panelists at any time using the Q&A box, which can be found by clicking on the Q&A button at the bottom of your Zoom screen. Please note that this session is being recorded and will be available starting tomorrow on the Office of Academic Clinical Affairs YouTube channel. We will share the link for the recording with you by email. Tonight, we have the privilege of speaking with a panel of University of Minnesota orthopedic surgery experts on the latest approaches to preventing osteoporosis, managing arthritis, and healthcare disparities. So let me introduce our panelists. First, we will hear from Dr. Suzanne Hecht. Dr. Hecht is an associate professor in the Department of Orthopedic Surgery at the University of Minnesota. She is a family medicine and sports medicine physician who provides care for a wide variety of individuals and specifically focusing on bone health and nutrition. Dr. Hecht, can you help us learn about bone health, including musculoskeletal health and its impact on overall health?
I'd be delighted to. All right. So thank you so much for having me. I'd like to thank the medical school as well as Dr. Van Heest for inviting me to speak on one of my favorite topics, bones and bone health. I did one of these mini medical schools many years ago, way before COVID, and it was in person, and we did it on concussion, which is another one of my topics, and I had a great time, so I'm really looking forward to participating tonight. So I really have no financial disclosures or conflicts of interest, but I do love bones, so I do want to share that, and this is my favorite quote, so I will just start out with that. And it says, to thrive in life, you need 3 bones, a wishbone, a backbone, and a funny bone. And that's credited to Reba McEntire. And I think that's a great quote to live by. Okay, next slide. All right, you guys are in medical school, so I made a quiz. So there's 4 questions. You're not going to fail or anything like that, but just do your best. So I wrote these questions. You can write your answers down on the side or put it on your phone or however, just try to remember. It's only 4 questions. So the first one is, what is the recommended amount of calcium intake for a 65-year-old female? And the answers are 500 milligrams per day, 2,000 milligrams per day, 800 milligrams per day, or 1,200 milligrams per day. Okay, next slide. This question is a true or false question. Number 2. Calcium and vitamin D are adequate treatment for a 70-year-old male diagnosed with osteoporosis. Next slide. Number 3, which of the following are risk factors for osteoporosis? Height loss of 1.5 inches. B, family history of osteoporosis. C, history of anorexia nervosa. D, all of the above. Okay, next slide. And last one is true or false. A vertebral body, so that's in the spine, insufficiency fracture with no trauma qualifies a patient with a T-score of -1.5, which is osteopenia, for a diagnosis of osteoporosis. So that one may be tricky. Okay, we'll circle back to these at the end. So if you could give me the next slide, that'd be great. This is an overview of the talk. I'm going to share some things about the bone and some facts that I think are important to know. We're going to talk about the definition of osteoporosis, some on epidemiology or how common is this. And then most of the talk will spend on preventing osteoporosis and try to delve into these categories. Next slide. So I'm a sports medicine doctor, work with Gopher athletes, so we always have goals in all of our talks. So the goals for this talk are to learn bone facts, recognize the impact of osteoporosis, know the definition of osteoporosis, understand bone acquisition over the lifespan, know clinical risk factors for osteoporosis, and learn steps to help prevent osteoporosis. Next. So I love this graphic because it brings the skeleton to life. And I think that most of the time when people think about their bone, they don't think about it as being a living, changing, dynamic structure. And they think of, the skeleton at Halloween, that's kind of static and hanging there, or one that might be in the clinic or something like that. But I think people are aware that their bones are alive when they actually break a bone. And the bones are, healing, and then they think about their bone a lot more. So the bone's like a magical organ. Next slide. So here are some top 10 bone facts. Next. Bone is alive. So I already alluded to that, and I'll share with you some of the cells that are helping to make the bone be a living structure. Next. It is building up and breaking down. So the bone is dynamic. It doesn't just sit there like that skeleton at the desk, but it's rather metabolically active all the time. Next. There are about 206 bones in the body. It's funny how people always ask me that question, and I often forget. And so I have to look it up, but it's kind of a fun little fact to know and keep handy. Not everyone has the same number of bones, but generally it's about 206. Next. The bones are super important for giving structure and protecting your organs and your tissues so that you wouldn't be ending up looking like a jellyfish, for example. Next. This is newer data that's been developing over the years, and we're learning that muscle and bone can talk to each other. And in fact, muscle can stimulate a bone in the cell to start regulating its other cells. So there's a lot going on there that we have yet to learn about. Next slide. These are the cell types I was referring to. So there's 4 main ones in the bone. This one's called an osteogenic cell, and that's a stem cell. And this cell is going to receive signals, and it's going to develop into a bone that helps build bone, an osteoblast. So those are the bone builders. And then there's a bone over here called the osteoclast, which is a bone breakdown bone. And these bones are the things that let the bone be dynamic and build up and break down and heal after maybe you have a fracture. This bone up here, the osteocyte, many people think of it as like the conductor, and it helps to regulate the mechanics between these bone types. Next slide. Okay, here's the rest of the list. I love this one. It takes 10 years to replace an entire adult skeleton. So that's a good one to know. I don't think we think about that very often. The bone has bone marrow and produces white and red blood cells, which the white cells are important for your immune system, red cells for your vascular system. There's 8 different types of hormones that have significant impact on the bone. So it sees these different signals from hormones and responds. It serves as the body's bank for 2 minerals, calcium and phosphorus. And finally, this is one of my favorites, bone formation increases with exercise. Next slide. So let's switch over to osteoporosis, which is a disease of the bone. You can read the words on here, but I think the picture is probably the most telling. So the bone on your left is a normal structure of the bone, and you can see all these sort of cross struts and this scaffolding, which makes the bone fairly strong without making it super heavy. And a person with osteoporosis, what happens to them is they lose a lot of these cross links, and this sort of scaffolding bone gets much thinner. And you could imagine that if you put a force on top of this bone, it's probably not going to accepted as easily as this bone would. Next slide. So how big of a problem is this? So I find this always very compelling, and that's why I like to share it. That women have a greater risk of having an insufficiency fracture per year than their combined risk of having breast cancer, heart attack, and stroke. And so when I read this, I always think, I think we should have, like, instead of a pink game, we should have like a white game for bone health. So it's often under-recognized, but it's a very important health problem. Next slide. These are just some more statistics. This is on a worldwide basis. And this is showing over here that globally, people over 50 years of age, women 1 in 3, and for men 1 in 5 will suffer an osteoporotic fracture in their lifetime, and that there's almost 9 million fractures every year, which is basically 1 fracture every 3 seconds. And this is an interesting statistic here as the population is aging, that the increase in hip fractures from 1990 to 2050 is projected to go up 310% in women or in men and 240% in women. Next slide. So how do you prevent osteoporosis? That's a great question, and it's one I love to have because sadly I see a lot of patients who already have pretty significant osteoporosis, are breaking bones without any significant trauma, and they're already in pretty big problem. I would love to see a much bigger focus on preventing osteoporosis. And so it's important to realize that this is a lifelong process and a commitment that starts actually when you're like a youth and before, even around age 10 or 11 or 12, when kids have no idea what they're thinking of. But you really have to start saving for your bone health retirement during that time in your life. And you could imagine if we asked kids that age to start saving for their retirement, their financial retirement at that age, that might be a tall order. So this is a really tough process. The genetics of this are super powerful, and the amount of peak bone mass that you attain at about age 30, probably 80 or 90% of that is determined genetically. So as one of the doctors I used to work with said, you have to pick your parents wisely. Unfortunately, some people are just dealt a bad genetic hand. So I put this little graph here, and you can see this starts at age 10. You start acquiring a lot of bone, and it gets very steep and through here when you're an adolescent, which is a tricky time, right? We know this from like kids who smoke and trying to get adolescents to understand the risks or dangers of smoking is very challenging. So this is one of the best times in your life to acquire bone. When you get about age 30, you kind of reach the most that you're ever going to acquire in your life. And then sadly, from there, you start slowly losing more bone than you put on over time. When you get around age 50, and particularly for women, around that time of the menopause, they lose rapid amounts of bone for up to 3 to 4 years following the cessation of their last menstrual cycle. I put this blue line here, as you can see, and so that represents somebody who, let's say they're 12 or 13 or 14, they're very sick, taking strong medicines, maybe they have an eating disorder, and they never really reach their peak bone mass way up here. Let's say they only get to here. And so they never acquire as much bone as they're supposed to do. And then once you're about age 30, you start like withdrawing on your bone bank account. And you can slowly get into trouble in a quicker time frame than somebody who's acquired much higher peak bone mass. So things that insult your bone, particularly in this time period, are very hard to recover from. Next slide. These are some risk factors for osteoporosis. The ones on the left are very difficult to modify, essentially. So age and race. So obviously, the older you get, the more likely you are to have osteoporosis or be at risk for it. Northern European Caucasians are the greatest risk from a race point of view of developing osteoporosis. Your body frame, so people that just tend to be smaller in general are at greater risk. Weight is obviously a little more modifiable, but It also is an impact, and being too thin is particularly challenging for your bone health. Sex, women tend to have lower bone density than men, and that has to do with generally women are smaller. And so that's why that is. And then family history, like I talked about, is very important. Some of the more modifiable types of risk factors are on the next column over. So smoking, drinking more than 2 drinks per day, certain medications like steroid medications can be very hard on your bone, poor nutrition, exercise is a really important piece. So for those who can't exercise, maybe people who are wheelchair bound, that makes their bone health less strong. Different chronic diseases can impact your bones, and some of these other things that I have listed. I did put up this little acronym. Medical students are famous for knowing acronyms. I'm not particularly good at them myself, but it's all the rage usually. So here's one you could think of for osteoporosis risk factors. It's called access, and it has alcohol use, steroid use, calcium, low intake, low estrogen, smoking, and a sedentary lifestyle. Okay, next slide. All right, so we want to try to prevent you from getting osteoporosis. So what we have to do here is really, I call it stop insulting the bone. And so the things that you can do that could really help your bone health are stop smoking if you smoke. You can limit your alcohol intake, and that can be very helpful. Increase your weight-bearing exercise is known to improve your bone density. You can try to minimize your medications that are known to be hard on bones. Sometimes that's not going to be an option if you have some type of cancer or something like that. You just need those very powerful medicines that are hard on bone. But there are other medicines that you can try to minimize. Try to gain weight if you're very underweight. That is a really helpful thing for improving your bone health. And improve nutrition. Next slide. So one thing you can do to try to prevent osteoporosis is get assessed to see if you have a problem with your bone health. And so the way to do that is called a DEXA scan. And this is a picture of, it looks like a male athlete laying on this DEXA scanner. It is a bit of x-ray, very little, about as 1/10 as much as getting a chest x-ray, or potentially as much as flying across the country in the plane. And it can compare your bone density to a time in your life, either when your own age folks, or if you're older than 30, it can compare you to a group of 30-year-olds who we think are at their peak bone mass. And that allows you to understand maybe how much people have lost over time. The DEXA is not perfect for sure, but it is the gold standard, and really all the treatment decisions and insurance coverage of medicines and things are based off a DEXA scan. It doesn't tell the whole story, and I will talk more about that. And it is definitely related to bone quality, but it doesn't predict everything about your bone quality. So it's a good tool, but definitely has some limitations. The World Health Organization says that you would diagnose osteoporosis and osteopenia based on these things called T-scores. And that's a conversion of what your bone mineral density is expressed as a T-score, which is a standard deviation away from how much you've lost when you're about age 30. Next slide. These are the sort of numbers for the T-scores. So to have normal bone mineral density by a DEXA scan, your T-score needs to be better than minus 1.0. To have low bone mass, or osteopenia is another term for that, your T-score would be between -1 and -2.5. To be diagnosed with osteoporosis on a DEXA scan, your T-score would be equal to or below -2.5, so minus 2.8, -3. And there is something called severe osteoporosis, which is when you have a T-score that's -2.5 or worse, and you've had an insufficiency fracture. There's also anyone who's had an insufficiency fracture from no significant trauma, assuming they don't have cancer in their bone, qualifies also for a diagnosis of osteoporosis. even if their T-score is perfectly normal in the DEXA scan. Next slide. So the next question is, who should be tested? And so there's lots of different organizations have different recommendations, and different insurance companies adopt different recommendations. The one I think is the best recommendations are from the International Society for Clinical Densitometry, the ISCD. And they recommend that any women who are 65 or older, or any men 70 years or older, get screened, whether they've had fractures or risk factors, that you should get screened for a baseline DEXA scan. If you're a postmenopausal woman who's less than 65 years old with risk factors, or men less than 70 years of age with risk factors. Anyone who's being considered for medication therapy for bone health, you should see where they're starting from. Anyone who is being treated, to see how they're responding to the treatment. Sometimes we treat people and their bone density keeps decreasing and they're not responding to the medicine. So without a DEXA scan, you don't really know that. And then anyone receiving therapy in whom evidence of bone loss would lead to treatment. So that's an important category as well. Next slide. I like showing this graph because this talks about why the DEXA doesn't tell the whole story. So this is the T-score of people's hips. And this is hip fractures in these patients where they, weren't in a car accident or something, but they were standing in their kitchen and their hip might have broken just standing there, or they fell down and it broke. And that's an insufficiency fracture. And what you can see on this graph is about 50% of the people have a T-score that's in the osteoporosis range, but about 50% of them have a T-score that's better. It's osteopenic, or even actually in the normal range. And that's one of the reasons we say DEXA doesn't tell the whole story. Next slide. I just want to say a few words about compression fractures in your spine. Ones that don't really come to medical attention, about 2/3 of them are like that. We find it sometimes on a chest x-ray or other imaging of the spine for other reasons. Things that can suggest that you have compression fractures is if you've lost 1.5 inches or more of height, or if you're hyperkyphosis, which means that you're very rounded over and hunched over. And the number one factor for predicting future insufficiency fractures is that you've already had one, and it increases your risk by about 4 times. Next. You don't have to know much about this slide. It's kind of frightening. But I put it up just to show you that if you are diagnosed with osteoporosis or osteopenia and you have bone loss, that you should get more of an evaluation to look for other things that either can contribute to osteoporosis or need to be treated and addressed in a different way. Next. All right, let's move on to calcium. I know I probably don't have too much time left, but this is one important topic. So it's the building block of the bone. It's very common to be insufficient, and there's some studies that have shown that kids, only 25% of boys and 10% of girls meet their daily requirements of calcium intake, and adults aren't, they're doing a little better, but they're still not doing great. Only 50 to 60% of them. Next. We like to look at calcium as the total amount that you take in. So your dietary intake counts. And I always tell everyone that if you want to get an A+ in calcium class, that you get it all in your diet. And for some people, that's pretty straightforward. Other people, that's much more difficult. For example, if you're lactose intolerant. So then you have to make up the difference with supplements. If you're not getting enough calcium on a daily basis, then you fail calcium. So the best is to get it all in your diet. The worst is not to get enough. And in between is some combination of your dietary intake and your supplements. I put this reference up here. There's a great calcium calculator that'll give you a lot of great ideas about calcium foods rich in calcium and how you're doing on your own calcium intake. Next. This is a great slide that just lets you look up what's the recommended amount of calcium that people should get. So I think there was a quiz question on this, so you might want to check it out right now. And the other good thing to do is maybe look up yourself. If you're male, you're female, you're pregnant, breastfeeding, what year, how old you are, and see what the recommended recommendations are. Next. I do calcium counseling with patients. I think of this movie 300, which is kind of violent, but I always do it in 300. So I remember the simple fact that there's about 300 milligrams of calcium in 1 cup of milk. And then things that are pretty similar to that are yogurt, ice cream, and 2 slices of cheese. So kind of once you know those factors, you can tell patients, well, you need to get like 3 or 4 servings, and here's kind of how you can do it. Obviously, there's other foods with calcium. I've listed a few below. Next. Vitamin D is a critical factor, and vitamin D is so important because it helps you absorb the calcium that you take in your diet. So if your vitamin D is low, but you're eating a lot of calcium-rich products, you're not going to absorb very much of that. And what happens is that your body needs that calcium for your heart. And so if it can't get it through the diet, or you can't absorb it because your vitamin D is low, then you end up taking it out of the calcium bank, which is directly out of your bone. Next. Here's just some general recommendations. There's a lot of various recommendations and controversies about how much vitamin D people should be taking. Probably the one that I follow a lot is from the Institute of Medicine. That's on the next slide. Can you advance? And this is one, and I like that they give kind of a recommendation, and then they also talk about what's the tolerable upper level that you could take in per day, and hopefully not get into any vitamin D toxicity, which is actually a pretty rare phenomenon. Again, try to take a look at yourself and see where you would fall. Next slide. I'm going to skip this slide and we can talk a little bit more about how to get vitamin D. One more. Can you advance one more? I just want to finish up with this. Osteoporosis prevention on exercise. Weight bearing and impact exercise stimulates bone formation. So I like to talk to my patients about surprising the bone. It gets used to what you're doing, just like if you do bicep curls, with 10-pound weight every day, you do 10 of them, your muscle's like, I got that. And the bone is exactly the same way. So the bone needs to have different forces on it. It needs to go forward, backwards, sideways, have some impact, change up the pace. And so changing up your routine and have a varied routine is really, really good for your bone. And weightlifting is also super beneficial for the bone. And, one of the newest fads is pickleball, and that's so great for bone health. So think about taking up something that you enjoy. Okay, let's go through the answers, and then I'm done. So number 1 was, how much does a 65-year-old woman need for her daily calcium intake? The answer is 1,200 milligrams per day. Next one, the answer is false. So we know that calcium and vitamin D for anyone, male or female, diagnosed with osteoporosis by itself is not enough to treat your osteoporosis. Number 3, the correct answer is all the above. And number 4, this one is true. So even if your DEXA scan shows a lower, a score that's not in the osteoporosis range, but you've had an insufficiency fracture, then you are diagnosed with osteoporosis. In summary, bone is an amazing living structure. It's a major health issue to have osteoporosis. You have to start young in your life to acquire as much bone as you can. Calcium and vitamin D are the key players. Stop insulting your bone if possible, and try to surprise the bone for bone formation from exercise. And I love this lady. She should inspire all of us. Thanks, everyone.
Thank you, Suzanne. That was really great information and good fun facts and info about bone health. So now our next speaker is Dr. Patrick Morgan. Dr. Morgan is one of my partners in the Department of Orthopedic Surgery and is an assistant professor. His specialty is adult reconstruction and joint preservation procedures. His practice includes hip arthroscopy, resurfacing, and joint replacement of the hip and the knee. Patrick, can you tell us a little bit more about joint replacement?
Yeah, absolutely. First, I just want to say thank you so much for being here. It's amazing there are so many people on this call that are interested in learning about joint replacements. So I might be biased, but I really do think that I have the absolute best job in all of medicine. Joint replacements have been shown to improve quality of life more than nearly any other intervention that we have in medicine. They are fantastic procedures that can greatly increase a patient's health span. Those years of life when we are independent and active and engaged with our world, they can really be transformative. And I can tell you, there's simply nothing better than checking in with your patients 6 weeks after their joint replacement and seeing that happen firsthand. Slide. So tonight, you can advance the slide, please. So tonight we'll go through the whole process of the joint replacement. We'll see what joints look like before surgery and the things that we try before going to the operating room. We'll see some of the technology that we use both to plan the surgery and to do the procedures. And we'll get an idea of how the typical person recovers from their procedure and gets back to their desired activities. Plan. So let's start with hip replacement. Slide. Truly the queen of surgical procedures. The modern era of hip replacement started in the 1960s, and it really revolutionized our ability to treat painful osteoarthritis. You know, there's a cliche of the cranky old guy sitting in a rocking chair on the front porch. In a very real way, one can imagine that he didn't want to be stuck in that rocking chair, that he didn't want to be cranky, and that instead he had end-stage arthritis and couldn't get up and move around. It just hurt too much. If he were here today, he would have a good option. So where did that guy hurt? If he was stuck sitting in that chair because of his hip, he hurt in the groin. Hip pain is groin pain. Why does the hip hurt in the groin? Because if you take your hand and you slide it into your pocket, your hand is sitting right on top of your hip joint. So in front of you here is an illustration of the hip. I have it up there so you can see two things. First, that the hip is a ball and a socket joint. It's a lot easier to understand what the implants look like when you remember what the hip joint looks like. And second, to show that each of those components, each bone is covered in a smooth articular cartilage at the end. It allows one bone to glide across the other. Slide. Okay, so here we are inside the hip joint. I took this picture inside of a hip joint with a little camera called an arthroscope. The ball and socket of the joint is on the left, and the socket's on the right. To take this picture, you just distract the hip open about 1/4 inch using a special surgery table. And I say that simply because I want you to remember that usually these things, the ball and the socket, they're right up against each other. Slide. So when you look at an X-ray and we talk about a joint space, there really isn't a space there. It's just what it looks like. So if you look above the ball, there's a darker line. That's what we call the joint space, but it's really 2 layers of articular cartilage that just don't show up very well on an X-ray. So that's a normal looking hip. Slide. Here's one that looks really arthritic. What that means when there's no joint space anymore is there's no cartilage, and that can be really painful. Not having any cartilage is called arthritis. That's what arthritis is. It's the loss of your tissue. You can see that one hip here already has a hip replacement. The one on the left side of the screen is really painful. This patient has groin pain, and he has it worse with hip flexion activities, even with sitting. When I see this patient, we will oftentimes start with non-operative management, activity modification, oral pain medication, consideration of an injection of a steroid into the joint, sometimes a cane. When that doesn't work, we will consider a joint replacement. Slide. As part of that discussion, I will usually show the patient a pretty detailed operative plan like you see above. The software that we use to get the surgical plan down to a few millimeters and a couple degrees is available in our clinic. And we do it for every case. We do it multiple times for every case to make sure we know exactly what we're going to do. Preoperative planning greatly increases the reliability of surgery, and they are just a super teaching tool to use in the clinic. It really helps patients understand what the procedure involves, takes the mystery out of it, and that takes a lot of the stress out of it. Slide. So what are these implants? Well, as we have seen, a joint is where 2 bones move against each other. In the elbow, it's the bones of your forearm and your humerus. In the knee, it's your thigh bone gliding along the top of your tibia, your shin bone. And in the hip, it's the top of your femur, the ball, and it sits inside a little depression in the pelvis called the acetabulum, the socket. Each of those two bones, the femur and the socket, gets an implant. In a modern hip replacement, each of those implants comes in two parts. On the femur side, there's a stem and a ball. And on the socket side, there's a metal cup and a plastic liner. You can think of that plastic liner as the artificial cartilage. It's the little white thing in between the ball and this shiny socket on the left there. This concept has not changed much over the years, but the materials that these are made up have improved a lot. The metal is no longer stainless steel, although they were for a very long time. Implants today are almost always titanium. And the plastic has improved a ton. It's actually improved enough that these implants can now last for multiple decades. That was really the biggest improvement in this technology since I started training. The metal implants, generally speaking, are covered in a very porous titanium surface. The patient's own bone will literally grow right into those little pores and lock these implants into place for decades. It's a super reliable technology that allows for stable, living fixation of the implant. And we are super lucky to have such a reliable and durable fixation. It's one of the reasons we can do these in really active people. So how are these implants put into place? Well, here we go. First, and this is the gnarly part if you're not used to surgery, the old femoral head is gently and lovingly removed. It's done with a small sterile saw, and it's done at the exact place that we planned for with that preoperative planning software we looked at. That's how we know we can get the things just right. With the ball removed, an instrument called a reamer takes a very small amount of bone out from the socket. And it does that so it's perfectly hemispherical and it matches that metal shell. With those bones prepared, we put in the metal shell and the plastic liner, and those are inserted much like a cork is fit into a bottle. And then the femoral stem is inserted into the femur. Now, very, very little bone is removed from the femur after the head is gone, and that's because the femur is already hollow. We then put the ball on the end of the stem and reduce the hip. We can generally do that operation in about an hour. And at this point in time, many people, especially young people, will simply go home a few hours later. Now, I want to point out something here that you may have noticed. The ball is quite a bit smaller than the original bony one. The reason is there needs to be room in the socket for the plastic. The plastic takes up a fair amount of the volume available inside the socket, and this reduces the size of the ball that will fit inside. Now, maybe some of you know someone who's experienced a dislocation where the ball has popped out of the socket. Generally speaking, the reason this can happen is super simple. It's the reduced size of the ball, and that smaller ball has a much smaller range of motion than your original parts. Slide. So how can you expect to do if you get a joint replacement or a hip replacement? Well, 90% of patients get a hip replacement will be very happy with their outcome. Now, for context, this is as high or maybe even the highest satisfaction that any surgical procedure has. Fantastic. And you can be very confident that there are several ways to put them in and several places to make the incisions. Sometimes these are called approaches. They all truly work equally well. They all work fantastically. Some will work a little bit better for others, but there's no real benefit to one over the other for a general population. We're just lucky enough to have a couple different ways to do it really well. It's important to talk about risks. What are the risks for getting a hip replacement? Generally in clinic, we'll focus on 4 risks. The first 2 are the risks of blood clots and infections. These risks can be reduced for most people to about 1% by taking simple medications. There's a risk of an injury to a blood vessel or a nerve because it's a surgery. These injuries are rare enough for a hip replacement that it's hard to give a very good number, but we generally say it's way, way under 1%. And finally, there is that risk of dislocation where the ball pops out of the socket. In the United States, that risk is about 4%, meaning about 4% of patients will have a dislocation of their hip replacement in their lifetime. That risk is lower at centers where a lot of these are done, and that's probably more like 1 or 2%. Slide. So with a good preoperative plan and a little experience, you can go from this to this. And a large percentage of patients, like I said, will feel well enough to go home that day. The rest of patients, especially patients who have any medical problems, they'll stay overnight in the hospital and usually go home in the morning. Slide. So who gets a hip replacement? Well, more women than men. Total hip is reasonably common. It's less than 1% of the population of people in their 50s, but it's up to 6% of Americans who are in their 90s. So it does increase in incidence over a patient's lifespan. Slide. And they're made for all kinds of stuff. They're made for hiking and biking and swimming, pickleball, which is obviously pretty popular right now. You can do a lot on a total hip. The only real activity restriction I tell people to have is that these implants really aren't made for running very long distances. I don't think it's like time to train for a marathon after you get your joint replaced. And they are not good for certain yoga poses, which puts you at risk of popping the ball out of the socket. But that's about it. So what about knee replacements? Well, first off, they are much more common than hip replacements. About 4% of Americans over 50 have a knee replacement, and there are 500,000 of them done every year. Interestingly, women are about 50% more likely to need a total knee, and that's for reasons we don't really understand. And like total hip, the average age is around 65 years old. Now, that number has gone down a little due to the improvements of the materials that we talked about, especially the improvement in the plastics. That just makes the implant more durable, and it allows younger patients to have a long enough service life to make the surgery appropriate. Slide. So here's the inside of a healthy knee joint. Just like in the hip, each bone ends in a beautiful pearly white cap of articular cartilage. And here you can see how different it looks as it really starts to wear out. This is when a joint can really start to hurt. You look at the x-rays, you can see that both knees here have bone-on-bone changes on the inside compartment of the knee. Just like in hip replacement, we will generally start with non-operative management, activity modification, over-the-counter pain medication that you can buy at the drugstore, injection of a medication into the knee, sometimes a cane. And when those are no longer working and the cartilage loss is severe, we can discuss the joint replacement. Just like when a patient comes in to discuss a hip replacement, I'll generally present a pretty detailed operative plan. Here, the implants you can see are in teal. And again, it's just a great teaching tool. It takes a lot of the mystery out of what a knee replacement is. And what are these implants? Well, the implants for a knee replacement are really different than for a hip replacement. In fact, I don't really think knee replacement is a very good term for it. With a hip replacement, we remove the ball and put in a replacement for that whole part of the top of the femur. A knee replacement, it's much more akin to crowning a tooth. You break a tooth, it hurts, you go to the dentist, he puts a cap over it, and it doesn't hurt anymore. That's the same concept here for a knee replacement. The end of the thigh bone lost its cartilage, you remove really thin wedges of bone from the bottom and you cap it. That's the implant at the top of these two pictures here. That's the femoral component. You can see from the front on the left, it's pretty wide, but from the side on the right, it's really thin. Then you do the same on the top of the tibia bone by removing a thin wafer of bone across the top and replacing it with a flat implant. Now you can see that there's a peg sticking down. That's actually a keel, like on a boat. That keeps this implant rotationally stable, so it won't loosen over time. That white thing that you see between the two pieces of metal, that's the same plastic that you saw in the hip replacement socket. It's just a great bearing material. We refer to it as ultra high molecular weight, highly cross-linked polyethylene. And that newer plastic has lengthened the service life of knee replacements just like it did for hip replacements. Slide. These implants can be fixed to the bone with that same porous material that bone grows into that we saw with the hip replacements. But interestingly, in knee replacements, that's pretty rare. The vast majority of knee replacements are fixed to the bone with a bone cement mixed in a little bowl that you see on the left there. Those of us in academic practices are pretty interested in this new generation of knees that don't use cement. But even if they turn out to be great, and previous generations weren't, they're probably going to be limited in their usefulness to people with really good bone who have relatively large bones so that it can absorb the force of it when it's first growing in. For now, most of us do the majority or the vast majority of our knees with bone cement. So with good implants and a detailed surgical plan, we can readily go from this to this. And this surgery usually takes about an hour or so, and many, and maybe even the majority for knees of patients now go home the day of surgery. It's really the patients that have medical problems that need to get observed overnight that will stay. The risks of the surgery are almost identical to that of the hip replacement, except the risk of dislocation, because knees really don't do that. Slide. And then what's the recovery like here? Well, I tell patients that the recovery for hip and knee, they take about the same amount of time. It's just the recovery periods are different. For the hip, the main work of recovering is walking and strengthening your muscles. For patients that limped for a really long time before their surgery, we also work on their gait so they can walk nicely afterwards. You don't lose your limp necessarily just because your pain goes away. Limping is sometimes a bad habit, and working with a therapist can help break that. For knees, well, it's more work. That doesn't necessarily mean it takes longer, but those weeks, I think they require a lot more effort. Much of that effort goes into exercises that simply make the knee get straight and then make it bend back. As you get arthritic in your knee, you lose a lot of range of motion. It's quite easy to make it move really beautifully in the operating room. It's hard to keep that motion because the knee has not bent that like that for a really long time. So that's what we focus on in the first 6 weeks or so. And we have resources to make that easier, including really fantastic physical therapists and what I think are best-in-class nursing staff. And the other thing I tell patients is it's temporary. Either hip or knee, when I see patients back for their 6-week visit, they're already 50% recovered. They tell me they've gone back to most of their usual activities, that they are driving, that they're back at their desk job, that they're doing their shopping. All those things happen sometimes between 3 and 6 weeks. And I can tell you by 12 weeks, usually most patients are 80 or 90% recovered and they're ready to go on vacation and have a nice time and just not think too much anymore about their painful hip or knee. And then at that point, we say it's graduation day. I ask patients to come back a year from surgery to get an x-ray. That's how we track how the implant is performing. And then after the 1 year, it's every 5 years. And with current implants, I think a reasonable expectation is a service life of 20 or 30 years. Slide. So that's why I think I've got the best job in medicine, because all we do is we get people back to doing what makes them happy. And it's a reliable, predictable procedure that's really durable. So I really thank you very much for your attention. And if anybody has any questions, I'm happy to answer them.
Thanks, Patrick. That's really great information about joint replacement, and we already have a lot of questions on that. But let's move on to our third topic. During these 3 sessions that we've had about bone across the ages, we've learned a lot about many aspects of bone health and musculoskeletal disorders. But our last topic is focused on examining our ability to provide that orthopedic care for all. It's my pleasure to introduce Dr. Helen Hudeman. She is a third-year resident in our orthopedic surgery training program. Each year, our residency training program recognizes one resident who demonstrates clinical interest, educational activities, and research related to DEI. Our 2024 DEI award winner was Dr. Helen Hudeman. She has demonstrated a deep care and a passion about addressing healthcare disparities within our community in Minnesota and global orthopedic care. Helen, can you discuss with us what's meant by orthopedic care for all?
Gladly. Thanks, Dr. Van Heest, and thanks everyone for the opportunity to speak to you all tonight. So I'll be switching gears a little bit, less of a clinical focus and more on a topic that I'm very passionate about. Let's see. Okay. So I'm going to be talking about orthopedic care for all and some special considerations for unique populations that we encounter as orthopedic surgeons. This is obviously a very broad topic, and I can't touch upon every group, but there's a couple that I have experience with that I wanted to share with you guys. I have no conflicts of interest. So the goals of this talk were to describe the demographics of those needing orthopedic care and identify at-risk groups, and then identify unique orthopedic perioperative considerations for high-need populations, specifically people experiencing homelessness and people in low and middle-income countries. So who needs orthopedic care? Kind of over these 3 sessions that we've had, it's pretty obvious, pretty much everyone at some point in their life will have some sort of orthopedic pathology, just given the wide range of what we do, what we treat, including, like we've been talking about, osteoporosis, joints, hand, pediatrics, trauma. Everybody will have some sort of pathology or condition. Not everybody will necessarily need surgery or need to meet with a surgeon, but it is a very common domain. To put some numbers in it, this is data from the World Health Organization, and it shows that musculoskeletal conditions are the leading contributor to disability worldwide. As the population continues to increase, the prevalence of musculoskeletal conditions will also continue to increase. And these are some numbers on what is most common. Low back pain worldwide is the most common condition, followed by osteoarthritis, fractures and trauma, neck pain, and amputations at any one given point in time. So obviously this is very important, and many of the speakers have described the different conditions and what we can do and what our options are. But we also want to talk about how we can best provide for people who may not be able to do all of the things that we've mentioned or have access to all of that care. So that's what I'm going to be talking about. So I'm going to start with individuals experiencing homelessness, which is something that we have a lot of experience with here during our residency in the Twin Cities. So looking at the numbers, on a single night in 2023, this is throughout the United States, about 20 in every 10,000 people were experiencing homelessness. And this number actually grew about 12% between 2022 and 2023. So it's getting worse. And it definitely affects minority populations more so. One example is that the Black population makes up 13% of total US population, but comprises 37% of all people experiencing homelessness. Looking at Minnesota specifically, for many of you that are in Minnesota, in January 2023, on one night, over 8,000 people are experiencing homelessness. Most of these are sheltered, about 80% in an emergency shelter or transitional housing. But again, it disproportionately affects men, minority populations, and we do have a large veteran homeless population here as well. So why does this matter? People experiencing homelessness are at an increased risk for musculoskeletal disease, and that has been shown. They also have a 3 times higher morbidity for fractures, dislocations, sprains, strains, or spine disorders. So not only are they at an increased risk, but if they get these conditions, there's higher risk of complications, morbidity, death, things like that. They also have a higher risk of exposure-related injuries and violence associated to traumatic injuries. And then infections are also very common among this population. So some of the strategies that we can do start at the beginning of when we see these people all the way through to as long as we can provide care for them. So these are just some strategies that we have employed in our residency and some of our hospitals that we work at to help provide care. So starting with the first time that you see someone, obviously with anybody, you want to establish trust and develop a rapport. But specifically, especially if you are uncertain whether someone is experiencing homelessness or not, approaching the history taking with compassion, imagining that everybody could be having a really bad day, and then make no judgments. I think it's a really important part of the history taking, especially for surgeons, is to figure out what their living situation looks like. And that can be very different for very different people, and that might change what we can do for people and what we have to offer them. Minimize computer time, ask how they would like to be addressed. That might not be the name that is on their chart. Using simple vocabulary. Again, this is something that we are taught in every field, but a lot of people don't kind of know. People will ask, is my bone broken or is my bone fractured? So kind of explaining what those mean. They're the same in our book, but using terms like broken bone, showing pictures to kind of help explain what we're talking about. Asking for permission. Sometimes for this population, this is the only part in their day where they have any sort of say of what happens to them. So be asking for permission of, can I examine your knee? Can I check your foot? That kind of thing, letting them be able to provide the answer of yes or no. And then if it's no, explaining why it's important for us to do so. And then also just one fact is that developing trust leads to increased adherence and better outcomes. So it is an important part of providing care. So then let's say we've hit the point of we have a history, we've developed a rapport. So what kind of things are we considering for this population in the preoperative period, so the period before surgery? Some things we have to know about the patients are their mobility status, so whether or not they walk, what they use to walk, and what they need to walk. So another consideration would be, is this someone who has to walk everywhere every day? Are they taking public transport? Do they have a wheelchair? Do they have access to a car? Are they able to leave and return? So there are many things that we see, especially from a trauma standpoint in the emergency department, that technically could go home and come back for either surgery or follow-up management later, but not everybody has the capability to do that. So understanding whether or not someone can do that is important. Baseline comorbidities. So this would be other conditions that someone has. For example, someone who is not able to see the doctor very often might have other conditions, high blood pressure, diabetes, that have never been treated or diagnosed. So some of that is included in our workup, and that can also affect kind of the orthopedic care moving on. And then just understanding that mainly in a trauma setting, but other settings as well, that getting these patients quote unquote optimized for surgery can be very difficult, and we may have to accept kind of different standards, especially for trauma. And then one important part of orthopedics is one question that we're always asking, can someone actually be non-weight bearing? So that means never putting any weight on the affected extremity. Very specifically for the lower extremities, this can be extremely difficult to do for someone who is housed and has access to everything. So it can be even more difficult for someone who is unhoused or doesn't have the same kind of access. So all of those considerations go into kind of what we're thinking about before surgery. And then obviously we want to include the patient. So once they are able to kind of explain what their needs are, we want to include them and ask them what their preferences are. If they are someone who is interested in trying to treat something without surgery or with surgery, and what the different options are. So then once we get to the stage of surgery, some of the considerations would be choosing a construct that allows immediate weight bearing. So again, going back to that, if we can provide someone with a stronger construct that allows them to put weight on it, even partial weight on it sooner, that might be a better option. So For example, we have different kind of ways to treat the same kind of fracture. That could be an external fixator, internal plates and screws, things like a hip replacement, like Dr. Morgan talked about. So different options may allow different weight bearing, and that can kind of play into a role of what might be the best option for different people. And then once we put the hardware in, we want to protect that hardware, especially if we need them to heal around that. So things like whether or not someone can have a cast or a brace, whether they'll be outside and that cast there's risk for that being wet, and maybe it's better to put them in a brace or give them things to help prevent that from getting wet. And then one other consideration would be options that can be completed in a single stage and don't require a lot of maintenance. So an external fixator, for people who don't know, is kind of a very big bulky thing that sits on the outside of your leg or arm. Sometimes there's rings around it. Typically, we don't have you put weight on it. Sometimes you can, but those usually require at least a second surgery, if not more than 2 surgeries, and often checks to make sure that those pins that are coming out of the skin are not infected. So that might not be the best option for all of these patients. And then postoperatively, after they're done with surgery, we do consider, maybe admit the patient, even if it's something that typically would not be admitted, so that at least they have somewhere safe to stay the night of surgery. They can have pain control. They get all of their information before they leave the hospital. So that would mean that all of their follow-ups, not just at 2 weeks, but kind of 6 weeks further out, are made prior to discharge and are written down for them. One example that I can say is we have patients who are given all this information and then will show up for their appointment, and they actually show up to the emergency department because they have no idea where the clinic is. So making sure that they are either pointed in the right direction or able to given a map of where the clinic is important. And then determining kind of the best form of communication for them moving forward. Now, not everybody will have communication. We can't call people all the time to remind them about their follow-up appointments. Not everybody has access to a phone or email. So making sure that we understand what they do have access to, or if there's someone else we can reach out to if we need to. And then one other consideration would be medications. A lot of people go home with medications after surgery, antibiotics, pain medications, anticoagulation medications. So understanding if they have somewhere to store that, or if they have, for example, if you're going to give them an anticoagulation medication that's an injection, if they have access to things or it's safe for them to be using needles. And then providing with additional supplies and then printing their summary for them so it's all written out. We do have social work in all of the hospitals that we work at, which is also very helpful. So sometimes if they're admitted, they can meet with those people. And oftentimes if there's a higher level of care needed that is unable to be provided back in their shelter or on the street, sometimes there are options like respite care. I won't go into that too much here, but it is something that exists and is a good option for people who need a higher level of care. So one case is going to be, 58-year-old male. He had a ground level fall. He sustained this trimalleolar ankle fracture dislocation. So his bones in his ankle are outside of where they should be. This ankle bone, the talus, is not underneath the tibia, and you can see there's some broken bones. He had insecure housing and worked as a snow shoveler. So he was put back in place. This is just under manual reduction in the emergency room. And then the conversation was had of what should we do? He had a strong preference for getting back to work as soon as possible and having surgery. He did not want to wait for this to heal on its own, which is typically what we'd recommend anyways. So we ended up doing a construct. We were able to do it the next day. His soft tissues allowed for that. And we were able to fix all of the parts of his ankle. So the outside, you can see there's a plate. On the inside, there's some screws. His ankle joint itself, so the square bone on the bottom is underneath the tibia, the shin bone. And just some additional considerations, he got some extra screws across that joint, which between the two shin bones, that provides some extra stability in case he did have to walk on it, though our recommendation would still be to not walk on it for at least a few weeks. And then he was put into a splint. If he was admitted, then we could consider transitioning him to a cast with some resources to not get the cast wet prior to discharge, or providing him with a follow-up visit in a week with a known time and location to transition to a cast for another 6 weeks. And then I'll talk about another population, the international population as well. So again, looking at the numbers, in 2010, an estimated 16.9 million lives were lost from conditions that needed surgical care across the globe. And 5 billion people don't have access to safe and affordable surgical care. 143 million additional surgical procedures are needed in low and middle income countries each year to save lives and prevent disabilities. So one benefit of what we are able to do is we're able to do surgical outreach trips. These have gotten some heat over the past kind of few years about whether or not they're entirely ethical. So one thing that I wanted to point out was some of the things that are helpful and goals of these trips to provide appropriate care, high quality surgical care that is able to be sustained in these countries. And then I'll touch upon one group that we work with that does this very well. So the goals of surgical outreach trips should really focus on providing high quality specialized surgical care, things that patients may not be able to access in their country originally. Educating local healthcare providers, making sure that people who are practicing there are able to understand where we're coming from, what we're doing, and maybe do some of the follow-up. Developing infrastructure, so we're not taking everything there and then taking it all away, and then promoting advocacy. So one group that we work with is One World Surgery. This is a nonprofit organization that provides cost-free primary and specialized care to underserved populations. They have 2 locations, Honduras and the Dominican Republic, and their surgical trips are typically a week long. This is kind of what their facility looks like. So they're a full-time surgery center. They're year-round. They have 3 operating rooms, 6 clinic and overnight bays, including a dental clinic, an eye clinic, pharmacy. They do have x-ray, and they have an electronic medical record, which is really helpful for us as we go, and we can kind of access that even when we're not there. They do have a full-time on-site medical director who's an orthopedic surgeon. So it's very helpful for our orthopedic brigades. And then full-time staff, 30 of them who are able to do consults and post-operative care. And then they have a visitor center that does also education for their existing staff and surgeons. So just some statistics about this group. In 2023, they served almost 30,000 patients. They had over 2,000 surgeries that were conducted in Honduras, less than 1% infection rate and a less than 1% post-op complication rate, which is really excellent for a surgical center that is providing free care with brigades. Some considerations, well, there's a lot here, and I know we're running low on time, but just some things for orthopedics specifically, what we have to consider when we go, whether or not they have specialized equipment that we need, what implants they have. We are often bringing some of our own implants from donations or other things. If they have cast and splint supplies, especially because these are patients that we are only there for a week. So if we need them to be casted, they'll have to come back. And we have to make sure they have the appropriate kind of stuff to be able to be casted and then to be able to get the cast off. All of the personnel for these trips typically come with us. So we bring translators, anesthesia providers, nurses, scrub techs, all of them come with us. And then other things to consider are whether or not people can go home the same day. Do they need devices like crutches, walker, that kind of thing? And then how are they going to be dealing with complications or the need for repeat surgery? Because obviously those things do happen. So this was our brigade. We had over 30 volunteers. We focused on a lot of pediatric care. We also have a collaborative education program, which is a partnership between One World Surgery and the University of Minnesota Surgical Residency and Summit Orthopedics. So in the picture, you can see me, our scrub tech, one of our staff, Dr. Bone, and then one of our Hunter and fellows, Stephanie. So we're operating together. They spend 6 months at One World and 6 months with us here training. So we get to collaborate with them and learn from each other on the best ways to provide orthopedic care. This was a case which we can skip just for time purposes, and then some resources. Thank you.
Thank you, Helen. That was awesome. And Helen was the recipient of one of our international scholarships to be able to be part of one of those One World Surgery Brigades. So thank you to all three of our presenters tonight. We have covered 3 really large and important topics. We have over 66 questions, so we certainly won't be able to move on to all of them. So let me remind you that each of the panelists tonight are practicing orthopedic surgeons for specific patient care questions. And I remind you that clinic appointments can be made with any of these physicians to address individual concerns. So let's start out with a couple of our more common questions, and maybe we could start with our overlapping question. We had several people ask, can a patient with osteoporosis be a candidate for joint replacement? Can we start with you on that, Patrick, and then maybe we'll follow up with you, Suzanne?
Yeah, that's actually a pretty sophisticated question. The answer is yes. There are specific implants that are designed to support bone that has gotten weak over time. And so we do that a lot, and it just has to be recognized beforehand, and the right implants have to be there, and those patients can do super well.
Well, that's great to hear. Any other comments about that, Suzanne, as far as optimizing patients for joint replacement if they do have osteoporosis?
Yeah, I think if it's identified ahead of time, it's a great thing to start treating. We certainly are doing a lot more bone optimization in large spine procedures. And there's some important studies and work that show that improving your bone health before those big procedures can improve your outcomes with less hardware loosening and less failure of bone grafts and things like that. So it's a good topic. And I think that if people have, strong history of osteoporosis, probably getting that looked into, if you can, before you have surgery, would be ideal.
We have a lot of questions in the Q&A box about calcium supplementation. The type of calcium with magnesium, vitamin K2 with vitamin D, and if there's differences by age and gender. Can you talk a little bit more about calcium supplementation, Suzanne?
Yeah, again, I think the main take-home message is to try to get most of it from your diet. That's better absorbed. And if you can't, then you can pick a calcium supplement. You don't have to buy anything expensive. You can buy something very standard, like Nature Made, something certified by the NSF, has good quality marketing practices and reproducibility of what you're getting in those supplements. There's different kinds of calcium. Some of that depends on people's tolerance for it. Some calciums are better absorbed like with a meal, and some are better absorbed in between meals. So there's a lot of small details about calcium supplements. Magnesium often comes with calcium because magnesium is an important factor in the bone as well. So it's a commonly made together type of supplement. And then there's a question about vitamin K2 or vitamin K. So vitamin K is a factor in some of the enzymes that help you to form bone. And in particular, vitamin K has 5 different subunits, and one of them is vitamin K2. And so if you buy some of the calcium supplement chews like Viactive, you'll see that some of them have vitamin K2 in it. And there's a fair amount of data from the Asian countries suggesting that that's valuable and helpful for treating osteoporosis.
And is calcium carbonate or calcium citrate preferred? What type of supplement is best?
Yeah, either one is fine. Calcium carbonate is one that gets absorbed best in when you've eaten, so in a more acidic environment, and calcium citrate is better absorbed in between meals, sort of in a more basic environment. And I think this becomes a key factor for a lot of folks who take proton pump inhibitors for heartburn and digestive problems, because if you're making your acid in your stomach always less acidic than it would normally be, and you use calcium carbonate, you're not going to absorb that very well. So I usually encourage those people to get down to the least amount of medicine that they need for that. And then after that, if they need a calcium supplement, should switch to calcium citrate.
That's very helpful. Helen, we have a person who has a boot after having an ankle fracture. Can that be donated?
Yeah, I didn't touch on this, but we do have a donation group. If you're in the Twin Cities, there's an organization called Healthcare for the Homeless, and we accept a lot of the gently used items and help donate and distribute either to respite communities or wherever they're most needed, so that information can be provided.
So I think we can send that out with some of our follow-up information. Patrick, could you talk a little bit about hip resurfacing versus a total hip arthroplasty?
Yeah, so what a cool question. If you look back 15 years ago, hip resurfacings were up to 20% of hip replacements that were done. And I do think that that's the right way to think of them, as a different type of hip replacement. They failed at rates that were thought to be unacceptable, but if you look into the data, patients that were young, meaning in their 40s, patients that had larger implants, basically men, and had these implants placed correctly, they did absolutely fantastically. And that's what I have seen in my practice as well. The failures were in patients who had osteoporosis, that had very small implant sizes. And those implant sizes aren't made anymore. So the way to think about it is the socket side is the same, but instead of putting a stem in, you crown the top of the femur just like you crown the bottom of the femur in a knee replacement. The really only advantage that I see for patients getting a resurfacing is that the risk of dislocation, while it's a possibility, is a super outlier. They basically don't dislocate. So in my practice, the classic patient would be a 40-year-old fireman. He needs to be able to do anything he needs to do to fight a fire, including crawling around in weird positions, and not have to worry about it dislocating. And he's going to be the size and have good bone quality to support that implant. So it's a niche, a small number of patients, but it still is an operation. People still really do benefit from it.
And we had a question, after a hip resurfacing, do you always need a total hip arthroplasty?
No, I mean, I guess it depends on how long you plan to live. If you look at the data, at 10 years, young men who get hip replacements, their implants are lasting just as long or longer than hip replacements. So you can think that some of these implants will go the duration and they'll never need to be converted to a total hip. And others of them will wear out over time and they'll get converted to a hip replacement.
Great, that's very helpful. Suzanne, I know this is a really big topic, but we have a number of different questions about treating osteoporosis. So calcium, vitamin D, diet, weight bearing. Are there other interventions that you could just briefly overview?
Those are some of the, what we would call the prescription medication interventions. And those are all really important as a piece of the treatment team. But once you've gotten to where you're diagnosed with osteoporosis, the studies are quite clear that those things by themselves aren't enough. They're going to be helpful, but they're not enough to really reduce your risk of having insufficiency fractures substantially. So then you start venturing into the different medication options for osteoporosis, which is a very large, complicated topic. So I'm not sure I want to spend too much time on that. But just know that, and I try to tell patients it's a little like imagine that you had hypertension, high blood pressure, and you tried, some exercise, weight loss, lowering the salt in your diet, and maybe you stopped smoking, and it maybe helped a little, but your blood pressure is still very high. You would need a blood pressure medicine, right, to help you really reduce your chances of having like a stroke, for example. So osteoporosis medicines are kind of like that, and I think that people understand that example a little better. So we're hoping to reduce the chances of, having an insufficiency fracture.
Yeah, and I think it's really important to know that you need to make an appointment to see a doctor and talk about what medications are available, and every medication has risks and benefits. There is a question, kind of follow up on that, is can you shift from osteopenia to osteoporosis and then with treatment back to osteopenia?
I do see that. Sometimes it depends on how deep you are into osteoporosis, or if you've had an insufficiency fracture, then you'll be labeled still with that diagnosis of osteoporosis, even if your T-score moves into an osteopenic range. So yes, there is some improvement and possibilities of that, but if you start at a T-score of -4 standard deviations below the average, your chances of that happening are very low. And what we're really interested in is not so much what happens to your bone mineral density, but what happens to your fracture risk. That's the more important clinical outcome. And actually, there's been medicines in the past that have been approved for osteoporosis treatment that improve people's bone density really well. But then they found when they had the fracture outcome data that the bone was actually like too rigid and it was fracturing more. So the fracture outcome data is the most important part.
Great. Yeah, because certainly fragility fractures is something preventable. And so that's a really important metric that we use. So Patrick, you talked a fair amount about total hip arthroplasty being so successful, 90% successful, 20 to 30 years of longevity. What about knee replacements? Could you give us some information about the success of knee replacements?
For many years, we thought that the success rate of knee replacements was inferior to hip replacements. I think that the more current data is that they're pretty equivalent procedures. What's really different for people, so like 85% or even higher of knee replacements are going to like them quite a bit, meaning they're happy with how they're doing, they achieve their goals of surgery. The real difference is it's more work to recover from a knee replacement. And so you do have to be ready for it. And if you are ready for it and you engage in it, people do great. And if you're not up for it, I think there are non-operative options that can get you most of the way there a lot of times.
And do you ever recommend a partial knee replacement versus a total knee replacement?
Yeah, this is sort of the equivalent of the resurfacing question.
Yeah.
Uni compartment, we call them unis, uni for one instead of, because the bottom of the femur is 2 condyles and we just replace one. Probably 5% of knee implants that go in. It seems like it's like a newer, innovative thing, but it actually came about even before knee replacements. The way that we use them is for patients that have just a really pristine lateral outside part of the knee and the inside part is worn. Those are generally people that had an injury to their knee, like a big meniscus tear, and had a lot of the meniscus removed. They are really neat implants. They feel more natural than a knee replacement because much more of your own knee remains. The downside of them has always been that there's a higher failure rate. And so the discussion in clinic with patients is, what are your goals and what is your appetite for risk? If your goal is to have the most natural feeling knee and you have a good compartment, uni is really a good thing to consider. If you just want something that's kind of bulletproof and get on with it, knee replacement is probably the way to go.
Great, that's super helpful. Suzanne, another question about osteoporosis. We have a lot of questions about treatment, but again, I think in most of those questions, we need to consult physicians individually because there's a lot of different considerations. But overall, how does osteoporosis affect fracture healing?
Yeah, that's an interesting question. It seems like there's a wide range of how it affects. And I usually counsel my patients who have osteoporosis that it may take longer for them to heal this fracture. Some of that probably depends on if they're actually being treated or not for osteoporosis, as some of those medicines may promote fracture healing in ways we don't understand very well yet. So I really see a range of things. Some people heal right up really well, but some of these people also have other issues going on, or other very powerful medicines that may be contributing, or poor nutrition, or other things that we have to think about sort of as a whole. Smoking, for example, is one thing that for sure can delay your fracture healing. And, does it make it worse if you have osteoporosis and you smoke? Probably because your bone quality isn't going to be nearly as good. And we know that smoking just by itself will suppress fracture healing.
Well, I wish we had time to get to all 90 some questions that were answered tonight. We certainly appreciate the participation in this webinar. Thank you to our panelists for your time and for sharing your insights into bone health as we age, advancements in joint replacement surgery, and addressing the orthopedic needs of all populations across our world. We would also like to thank you, our participants, for your participation in the Mini Med School and for joining us for this 3-week series on bone across the ages. So thank you very much and have a great evening.